Catherine Langevin. I'm the Senior Advisor, Knowledge, Advocacy, and Partnerships in the HIV and AIDS section, UNICEF, New York. I'm very pleased to welcome you to the webinar on Disclosure of HIV Status Toolkit for Children and Adolescents, co-hosted by UNICEF with the Elizabeth Glaser Pediatric AIDS Foundation, EGPAF. I'm so honored to be here with my colleague, Dr. Nande Putta, Program Specialist on Child Survival, and the EGPAF colleagues, Dr. Natella Rakhmanina, EGPAF Senior Technical Advisor, Dr. Judith Kose, EGPAF Regional Technical Advisor on Pediatric HIV, and Joshua Ochieng, a member of EGPAF's Committee on African Youth Advisors. I'll briefly introduce the speakers at the start of their presentations. I just wanted to say a few words about the format of the webinar before we get started. Dr. Putta will introduce the topic, then we'll have a presentation of the toolkit by Dr. Rakhmanina and Dr. Kose, and a presentation by Joshua about how the toolkit was developed with meaningful youth engagement. The presentations will take about 30 to 35 minutes in total, followed by about 10 to 15 minutes for Q&A. We'll take all questions using the chat feature, and you can start sending the questions as they occur to you during the presentation, even though we won't be addressing them until the Q&A period at the end. We'll be monitoring the chat for the whole time of the webinar. Some of you have been listening in as we were sort of talking among ourselves at the beginning. If you're having trouble with the audio, please send a chat message and we'll be communicating privately to those of you who write to us with the technical issues. I just wanted to add the webinar is being recorded, and please mute your mics as we get started. I'll introduce Dr. Nande Putta. She's the Program Specialist, Child Survival at UNICEF. She's a medical doctor, epidemiologist, data scientist, and public health leader with over 15 years of experience managing teams and collaborative partnerships to yield results for the health of newborns, children, adolescents, and women. She's worked with UNICEF in Kenya and New York since 2011. Over to you, Nande.
Good morning, everyone. I'm really pleased to be here to speak to such an important subject. Disclosure is a recurring theme. Disclosure is a recurring theme in our programming, as well as in the evidence, as being a key barrier to uptake of services by children, adolescents, infants, and also a key barrier to adherence and retention. I think this is so timely in terms of us being able to overcome this barrier and improve the uptake of services so we have better outcomes for children. I'll begin by walking us through the definition and the different types of disclosure, just to set the base and pace for our colleagues who are going to go into the details of disclosure as they are outlined in the toolkit. So the definition of disclosure, and this is with reference to the toolkit, disclosure of HIV status is not a one-time event, but rather a process involving ongoing discussions about the disease as the child or adolescent matures cognitively, socially, emotionally, and sexually. 4 types of disclosure have been identified: full disclosure, complete non-disclosure, accidental disclosure, and deception. Full disclosure is referred to as providing full information and knowledge about HIV. Complete non-disclosure is referred to as maintaining complete secrecy around diagnosis, not telling the truth, or not providing any information about the diagnosis. Accidental disclosure is referred to as telling the child or adolescent about an HIV status without preparing them and disclosing to them by accident, usually done unintentionally. Deception is referred to as ascribing the child's or adolescent's condition to a different illness or linking the child or adolescent's behavior and appearance, e.g. for not eating enough, frequently coupled with non-disclosure. I'm sure to some of you, what I've read to you might feel familiar or seem familiar from your practice, but we're going to receive more details, and I would like to hand it back to Catherine.
Perfect. Thank you so much, Dr. Nande Putta. Our next presenters are Dr. Natella Rakhmanina and Dr. Judith Kose, both from EGPAF, who will present the toolkit. Dr. Natella Rakhmanina is a senior technical advisor at EGPAF. She's also a professor of pediatrics at the George Washington University, and she serves as the director of the HIV program at Children's National Medical Center in Washington, D.C., USA. She's been providing clinical care to HIV-infected infants, children, and adolescents for nearly 20 years, and she's a successful clinical researcher within this field. Dr. Judith Kose is Regional Technical Advisor on Pediatric HIV with EGPAF. She's a pediatrician with subspecialty in infectious diseases and with experience in clinical and operational research. She's a public health specialist with over 15 years of experience managing multi-donor health programs and providing targeted technical assistance and leadership in pediatric HIV within EGPAF country and global programs. I'll now hand the floor to the two presenters.
Thank you, Catherine, and thank you, Dr. Nande, for the wonderful introduction and the major definitions. This is Natella Rakhmanina speaking, and we will do joint presentation with Judith, Dr. Kose. I will start describing the settings in which we were able to develop this tool, some major elements of the tool, and we'll pass it on to Dr. Kose to describe the validation of the tool which took place on the continent. So let me start by just continuing on what Nande has just said. It is really a remarkable problem of disclosure that is on the way of many providers, many families to the happy and productive lives and to living a certain lifestyle. And disclosure is hampering not only the care, but it's hampering people's capacity to really enjoy life and living freely and positively with HIV. So we have, as many of you, been aware of this issue. We also have been aware for many years working in our countries that the disclosure is a difficult issue to handle. It's something that requires a certain level of understanding and training and capacity to do that. And the healthcare providers, along with the community, have struggled with doing it the right way. As you heard, I've been doing clinical practice for almost 20 years, and I still sometimes am faced with a quite unpredictable circumstance to handle the disclosure, which makes me really think through how to handle it. So it is a challenging task, but it can be done. And when it is done right, it really empowers everyone. It empowers all ends of the continuity of the care and retention. So we, with that knowledge and with attitude that I just described, embarked on working on the tool. The work around the tool came around the New Horizons Collaborative, which we run with the support of Johnson & Johnson and coordinate the major activities within the initiative with the support of that initiative. New Horizons Collaborative is a program that has a vision of the world in which young people living with HIV lead full and healthy lives, achieve their aspirations, and reach their full potential in life, just as I mentioned recently. And the mission of the collaborative is built around the donation of the drugs, but it's really way beyond it. It's really to be able to see those who have failed the regimen on the first line due to multiple circumstances and really need to change the drugs and to move on with controlling of this, allowing them to have a holistic integrated approach, and really for us to be able to them in any way. This collaborative has been launched with the support of Johnson & Johnson, and we were a moderator on the continent in 2014. It's now 2019. We have quite a few countries that joined it. And as a part of this collaborative, we called yearly meetings with the representatives of country pediatric adolescent treatment experts, representative of the youth community, representative of the ministries of health, drug suppliers, etc. And during those meetings, one of the technical areas that kept coming back was the need for the support for disclosure. And one of the very strong messages we heard was, please make it short, please make it for us handable, please make it the way that we could easily scale this up. There are wonderful resources already. And before I move on describing our resource, I really want to say there are so many people who think the same way and work the same way. UNICEF is hosting this webinar today. It's just an evidence and Dr. Nande introduction to how important this topic is to this organization. UNAID setting up 90 targets also speaks about the need to really have a great output of treatments, which we know are not achievable without the disclosure. Particularly in Horizons Collaborative has a target of having 5,000 pediatric patients on the second, third line to living healthy, alive, being retained in care and being suppressed by 2020. So we do know there are a lot of people and a lot of collaborators, USAID, PEPFAR put a great work, ANECA. There are multiple partners who have addressed disclosure, and they're great resources. What we have heard from the countries in our meetings, please make something short and scalable. We want something that can be easily brought in the field, can be easily scaled up. So our goal was to develop the tool based on wonderful resources available and to develop it in a short format that is easily scalable and accessible through our country programs. So I will start by addressing the disclosure that's most frequently talked about, but I will mention a lot of other disclosure scenarios. As Dr. Nande started introduction by describing 4 types of disclosure, most of the times people talk of disclosing the status, HIV status to the child or young person who had acquired HIV in perinatal period, would it be at birth or during the breastfeeding or during the pregnancy, and somebody who grew up with HIV and doesn't know he has or she has HIV. But the disclosure is by far more complex issue and there are much more behind it. But let's focus this on this one that is most frequently mentioned right now. WHO, World Health Organization, does recommend that all children of school-going age 6 to 12 be told that they're HIV positive. There is no clear timeline when you should do it. Nobody can say at 10th or 11th birthday you should know your status. There are many factors that affect the capacity not only of the person to deliver that information to the child, but to the child to understand, withhold this information and handle it properly. We have looked at the disclosure prevalence through a lot of studies and resource limited settings specifically, and we have found out some papers that reported disclosure rates being as low as 0% among the patients they cared for or they analyzed, up to 69%. But you can see no number of 100 here. Factors influencing disclosure, as I mentioned already, is child age, child's developmental stage, because you can be of 10 years old, but you have a major developmental disorder and are not able to process information. Obviously, age is not your measurement. Perceived ability to understand what HIV is, and I really like the citation by Dr. Nande about the process. It is a process. Just by telling somebody something one time doesn't mean they retain this information. And what they want to know at the age of 10 is very different of what they want to know at the age of 14 or 16 years of age, when the sexual maturation and development comes as a part of the normal growth and development. Caregiver educational level has been cited in papers as one of the factors influencing disclosure, how well caregiver can handle medical information and understand it fully. And caregiver openness about their own HIV status in case of the caregiver being also a person living with HIV, which you all know is not always the case. And when it is not the case, that can also be a barrier or the challenge, because the person who doesn't have HIV might not fully embrace and understand the importance of the knowledge of your own diagnosis. Among common barriers, which we also have all knowledge of on the ground is a fear that the child will disclose HIV status to others. In fact, that's what you hear from majority of the providers. They're very worried about stigma in the community, rejection, and not only rejection for the child personally, but the whole family. Concerns of child's emotional and physical health. How will the child grow and see the life in a beautiful light when he or she knows that they have a disease that is currently not curable and will be with them for the rest of their lives? So as we go on disclosure practices, and we have tried to analyze those, we have seen that people do different things. Some countries choose to move on the early disclosure, at least partial disclosure, when you don't fully reveal the name of HIV, as early at the age of 4 to 6 years in Tanzania, 8 to 10 years in Rwanda, and these are just few examples. Full disclosure is handled quite early in some settings in Zambia, but it is delayed to the adolescent age for countries like Rwanda. Again, child maturity, child needs, and his or her understanding are very important. But what's most important is to start a dialogue with caregivers way ahead of time. This is a joint process between the healthcare worker and the caregiver, and it is better to start talking about it way in advance. Healthcare workers can play a crucial role in empowering caregivers to disclose or assisting them in doing so. And finally, if there is a case scenario where the caregiver just isn't comfortable talking about the HIV, it should be a healthcare worker who could take this task on their own and go on. So the toolkit components are evidence-informed, and I just want to really emphasize that this is where you can download Toolkit that's totally free and can be downloaded and printed, and you can choose maybe certain parts of it. We used a lot of resources from published papers, review published papers, original studies, to the available multiple resources by stakeholder, which I mentioned in the beginning of the talk. We have included their guidance and checklists for disclosure by the different cadre of people who might be doing the disclosure. So there is a guidance and checklist for disclosure if it's carried by healthcare worker. It provides the health worker with a very important tips and the flow of the disclosure preparedness, carrying it on and following it through. There is also guidance and checklist for disclosure for caregivers. Would they be doing it either by themselves at home or with the support of healthcare workers? We also wanted to open disclosure way beyond perinatal HIV, and there is a whole section of the tool that really focuses on horizontally infected adolescents. If the young person has acquired HIV through the sexual relationship, how are they going to tell it at home? Many times they have to reveal also their sexuality at the same time, and this is a very difficult task. And finally, there is also a whole area of the disclosure tool that addresses a very important issue of adolescents living with HIV, both perinatally acquired and horizontally acquired, and handling in the current environment of social network, community, and the partners with whom they build personal relationships. The disclosure tool includes job aids, which provide you with some algorithms. You can see on the right a cartoon demonstrating some of the tips or example of the conversation that can take place, and Judith will talk, Dr. Kose will talk more about that. We also include readiness assessment checklist, and I will show you in a minute, and the role-playing scenarios, which to me as a medical provider is one of the most important crucial elements of this tool, because it allows people who are using it to really exercise the disclosure by taking the roles of different people in the community and healthcare system and handling it as it was in their own lives. Structure of each model for disclosure includes first description of benefits and barriers for the disclosure in each particular scenario. So if we're talking about perinatal HIV, we're going to address benefits and barriers there. If we're talking about horizontally acquired HIV in adolescents, accordingly benefits and barriers are related to that particular scenario. Includes readiness assessment, as I mentioned, disclosure tips, really practical tips in a very short format, bulleted points, and key talking points that could be used and modified in a culturally appropriate manner. Post-disclosure evaluation and follow-up are crucially important, and these also are included in our models. This is just an example of the readiness assessment criteria. You see a table on that slide. This one particular relates to 10 to 14 years of age, and it is related both to partial and full disclosure. And you see it broken down by 3 areas. One is just major elements that you need to take into account when assessing whether adolescent is ready. The second one, orange line, is assessment of the caregiver readiness. And finally, joint assessments with adolescent and a caregiver. And again, it is just to be used as a guide where people can read and put the check marks. They don't have to do it on the paper in the chart. It can be just something that they keep in their mind. But this is just some general guidance. What are the important elements to take into account when moving on with the disclosure? Another example on the next slide is a disclosure algorithm. You can see here the steps of the disclosure. Those are related to the eligibility criteria, readiness assessment. So before we even start assessing readiness, we need to know whether the child has at least developmental age of 6 years or above. Please notice, not a biological age, but developmental age. Whether there are severe physical or psychological illness ongoing, which can affect the capacity of the person to even be approachable disclosure, and whether caregiver is at all willing to disclose. Step 2, readiness assessment counseling, and then disclosure counseling that goes on the step 3. Again, very important element is post-disclosure assessment. Once the person in any way has heard about the HIV diagnosis, would it be partial disclosure or full, it's very important to continue the dialogue and to recognize that it is an ongoing process. And then referral and support for any additional services as a step 5 to support the process and life going forward. Role play and scenarios, this is just one of the examples. This is again something we are particularly proud of for each of the models, including perinatal disclosure, horizontal disclosure. We have 3 role play and scenarios with the names. We try to develop them in a very culturally sensitive manner. We try to develop them a little bit in a way that could capture the people's attention and get them really involved and passionate about the situation. And then the idea of this training is that people can take on different roles, which we provide a list of to assign the roles, and just play different scenarios and exercise the understanding and capacity of handling disclosure. With that, I finished my part of just walking you through major structure and elements of disclosure, and I'm going to pass it to Dr. Kose, who will talk to you about how we validated the tool in different settings. Dr. Kose, to you.
Thank you, Natella, and thanks, Nande, and also thank you, Kathy, for the introduction. So as Natella mentioned, I'm going to take a few minutes to talk about the validation we did. So the purpose of the validation was to make sure we get feedback to enrich and improve the toolkit and to make sure it's relevant for our population that is going to use it. And the methodology we used for the validation was through meetings to receive feedback from healthcare workers. So we had both small group discussions using a standard small group discussion guide, and the focus for this was to get feedback on the structure, the style, clarity, and content. And we also had individual feedback using individual feedback questionnaire for usefulness of the content. So that's the methodology we used for the validation. We did this in 2 countries, in Kenya and Lesotho, a total of 13 facilities, as you can see on the slide. And the representation during the participants included healthcare workers like clinicians, nurses, peer supporters, pharmacists, adherence counselors, psychologists, and also social workers. So basically, people who have been involved and who do a lot of disclosure and support for pediatric and adolescent HIV services. Next slide, please. So in terms of the main findings, so majority of the participants reported that they have really worked in the HIV field for a while, 5 to 10 years. They found the tool to be feasible and very useful, and in particular in the case for Kenya, they found that it complements well the disclosure checklist that is used, that was already in use. So this was a good resource for them to be able to use it effectively. And both countries found the information on the disclosure in terms of definitions, and processes to be very useful. And in fact, they were asking us for more reference materials to read. And in terms of the most useful, they found the disclosure algorithm that Natella already discussed to be the most useful component. And they gave us additional feedback to add, including the adherence monitoring post-disclosure. Between the two countries, we had some country-specific differences. For instance, the role of healthcare worker in disclosure. In Lesotho, disclosure is seen purely as a caregiver role with not much involvement of the healthcare worker, while in Kenya it was seen that there are times when the healthcare worker will support heavily disclosure for the caregiver with permission. So, and also the existence of disclosure tools was a bit different. We found a lot of tools in Kenya, and Lesotho, they didn't have much of the tools, so they really appreciated having this toolkit. Moving on to the next slide. From the validation, the main themes were around adding language and content on healthcare worker support in schools, community and faith settings. There was a proposal to address issues of accidental or unintentional disclosure. There was a request for more graphics and pictures, and we addressed this. And also there was a request to increase, especially from the Kaya, to increase the amount of role plays and more scenarios as a practical guidance for healthcare workers. And we listened to this feedback and incorporated it in the final version of the disclosure toolkit. The next slide is just a pictorial showing some of the input we had from the Kaya members, and Joshua is going to be talking about it. This just gives some wordings that the Kaya members gave that someone can use when they're being counseled on accepting their status. Some of the wordings they can use to help them be able to live with their HIV status. And my next slide, and I think this is my last slide, in terms of next steps, for the disclosure toolkit, we now have a French version available, and there's a link on the slide if anyone is interested to download. We have the Portuguese version that's going to be available soon. And right now, what is going on is that there's a lot of dissemination by EGPAF offices. But apart from that, Uganda is working with the Ministry of Health to get this disclosure toolkit language integrated into MOH guidelines to support its use. Zimbabwe is working to get the resource co-branded with MOH so that there's better buy-in, and there's a lot of capacity building using the tool in many countries, including Kenya. Thank you very much.
Thank you so much, Dr. Rakhmanina and Dr. Kose, for the presentation. We're going to move right into the next presentation, and we'll have a proper Q&A period at the end of the presentation with Joshua. I'd like now to introduce Joshua Ochieng. He's a 21-year-old young man living with HIV in Kenya who struggled with adherence from an early age due to stigma and orphanhood. His experiences inspired him to take on peer leadership roles and become active in local HIV youth networks. He's currently studying community development at Maseno University and serves on EGPAF's Community of African Youth Advisors. So over to you, Joshua, with thanks.
Thank you so much. My name is Joshua Ochieng. I am from Kenya, and I'm 21 years old, talking to you from Kenya right now. I want to take you through how I got to where I am today. First and foremost, I was born with HIV. My parents knew about my status when I was 4 years. They passed on when I was 9 years old, and I didn't have knowledge on my status until later on when I was 13 years old. I had poor adherence, and therefore I had to be disclosed to about my status. My disclosure was not so much easy, but I was disclosed to through my clinician and in support with my aunt. The clinician made me friendly. He always taught me and gave me words of encouragement. She always gave me words of hope. She wanted me to become somebody in life. And I accepted my status after some period of time. Then later on, after accepting, I passionately discovered that I can do a lot in conducting PSHGs and inspiring adolescents and young people through positive lifestyles. I am currently a student at Maseno University and I'm taking diploma in community development. Next slide, please. I want to take you through what Kaya is and how it works. Generally, Kaya refers to as Community of African Youth Advisors. It comprises of 20 young people and 11 countries in Africa. Each country has 2 youth representatives and a Kaya focal person. The Kaya focal person is an EGPAF staff who helps us to participate in monthly Skype calls, undertake tasks, and discuss upcoming tasks. Generally, Kaya is an internal technical advisory group. Moving to the next slide, please. Kaya's review and feedback role in this disclosure toolkit. As a Kaya, we gave out our inputs in the 3 subsections, as you can see in the slides. For example, in the caregiver slide, we gave out that caregivers need to be involved in disclosure to enable reduced stigma, to strengthen psychosocial support, as well as to encourage adolescents and young people to enhance their adherence. We also looked at the social networks, for instance, in schools, friends, and places of work, where we gave inputs that adolescents need to disclose their status so as to ensure their social support. We also gave input on partner, and we realized that adolescents and the young people, they need to disclose to their partner so as to reduce secrecy, to reduce stigma. Just as we had been told in the introduction, that stigma is still a situation. We didn't stop at that point, but we realized that disclosure requires a lot of people, requires many people, so we gave out inputs on these people that are required in this disclosure. For instance, we gave advice that healthcare workers who are involved in the disclosure process need to use simple languages and simple tone variations whenever they are speaking about disclosure to the adolescents. We outlined the benefits of disclosure from a client perspective, where we discussed that it reduces stigma, it enhances adherence, it enhances positive living. We also gave out the challenges. As we know, something that has a benefit might have challenges. And we gave out that challenges may be, can lead to some stigma, can also lead to discrimination. But we didn't stop there. We realized that even though the challenges of disclosure may be a problem, but we gave advice on unintentional disclosure. That we gave that, for instance, if one experiences an intentional disclosure, we gave out that when somebody knows about your status, it should not be that your dreams are shattered, but rather use that opportunity to actualize your utmost potential. Next slide, please. The Kaya contributions in 7 countries has led us to the following. 1, we have formed a WhatsApp group using emojis and hashtags. Know your status as I know mine. The Kaya also suggested cartoons to communicate disclosure. We gave advice on accepting one's status to motivate peers. In Kenya, the Kaya team, Lydia and I, in support with Dr. Justine, we suggested healthcare workers' questions that can be used to assess readiness and willingness of adolescents living with HIV to disclose their status to their social networks. Such questions were, what is the age of the person you intend to disclose to? How long have you known that person? Is he or she trustworthy? Next slide, please. This disclosure toolkit has given up to some results, which are, so a lot of teams have decided to use it down. For example, in Malawi, the Kaya team began using it in teen clubs to support partner disclosure. While in Zimbabwe, the technical director and the Kaya members presented the toolkit to the Ministry of Health for national adoption. We also, as Kaya team, we identified new resources to address disclosure, stigma, shame, and myths. And this we did it through cartoon creations, which we developed by use of Harvard. Thank you so much.
Okay, terrific. Thank you so much, Joshua. Hearing the presentations, I just wanted to congratulate EGPAF for such an excellent toolkit, and also, knowing that the involvement of young people like yourself really enriches the whole process. We now have a 15-minute session on Q&A, and this will be moderated by Dr. Nande Putta. We haven't seen any questions coming up with respect to the technical content of, with the substantive content of the webinar. They've been mostly technical questions that we've been seeing on the chat, but it's open now for those of us who have questions, and we'll take a few at a time for about 15 minutes. So should you have some questions, please do send them through on the chat. We're sitting around the table here, and a couple of questions have come up. I'm wondering maybe if I could kick it off by asking to Dr. Rakhmanina and Dr. Kose about the sort of the universality of the toolkit. So it's a global toolkit. It can be used in all cultural contexts. I think you mentioned the language editions, which is specifically for certain contexts, but I'm just wondering, how were you able to ensure a sort of representativeness of the audiences that you were addressing the toolkit to? And then another question that has come up around the table here is in the process, in the actual toolkit process, when questions come up about sort of difficulties that the health workers have, or that the caregivers might have in disclosing, how those can be overcome, and if that's addressed in the toolkit. And we have a third question that has come in about, just scroll up a bit, from Linda. Are there recommendations for post-disclosure support? She's thinking about psychosocial mental well-being support. So why don't we start with those three questions, and Nande will moderate. I'm sorry, I sort of took over there a bit, but
Sure. I will start the lead, and I will ask Dr. Kose to add anything I miss. Thank you very much. First of all, we want to thank you also for the platform, because we want definitely to recognize the New Horizons support for that. That work would not have been possible without the whole collaborative and our capacity to work together. And I just want to start by saying a little bit stepping back and saying how we came. I mentioned briefly that the call for the tool clearly came from the countries, and New Horizons currently has 10 country members on the continent representing very diverse settings. As we hold our annual workshop, which usually is held in the fall months of October and November, we, in preparing for developing this tool, having heard already the need for such tool, we actually have asked our country member participants to present each country on the practices of disclosure. It was a very comprehensive presentation. Since in the room we had representatives of Ministry of Health, but also a lot of pediatric adolescent experts who actually are involved in the clinical work and know exactly what's happening. That was a very good starting platform to make this tool universal. So again, we started by hearing how it is being done, where the barriers and challenges are. When we developed it in terms of language, even if we used any specific resources, we really tried to remove any context from there that was relevant to a particular country settings or to the particular care settings, and take more global and more general points to incorporate. And to the question of making it culturally sensitive, even in the names, we have consulted with not only Kaya members, but the community, and during the meeting, we consulted which names would be appropriate, relationship within the case place scenarios. We also consulted a lot with the community and the providers as well. So we actually conducted informal interviews with some of them. Parents and caregivers, we haven't formally included it, but many of us who are providers, we know what they are saying, and we have shared. And there is a part of the tool which carries some kind of, what we try to do is quotes, which we heard from clients and from the healthcare workers about disclosure experiences. These are direct quotes from direct people. They're obviously all anonymous, and any identifying potential even style has been slightly modified. But this is how we try to make it applicable across all the settings and make it yet very, very global. And so I hope I am able to answer those two questions. And I think the first question, I think validation process was also the one that helped us to really make it more global, especially since the validation was carried in the settings of very different countries and very different systems. I don't know, Dr. Kose, if you want to comment on that.
Yes. Yeah, thanks, Natella. Very quickly, I think the other thing that makes it universal is the type of facilities that represented during the validation. So both in Kenya and Lesotho, we had like in Kenya, we had facilities in Nairobi and in Homa Bay, which is more in the rural area, and we had different types of facilities. In Lesotho, we were in Berea district, but we had hospitals and health centers, so different sizes of facilities were involved. But even the type of participants, we had doctors, nurses, youth representatives, peer supporters, counselors, pharmacists, and psychologists. So we had a good mix. So that makes it more rich because we had input from different categories of facilities and staff as well.
And thank you, Judith, very much. And to close on this round of questions, I will go back to the question number 3 about post-disclosure. Yet we have a very concrete advice on how to handle post-disclosure, including mental health evaluation, psychosocial support. I really want to emphasize that our approach is that it is an ongoing process. We don't see, and you will see it reflected in the tool, that the post-disclosure is equally as important as disclosure itself. And then reassessment of the disclosure retention is also mentioned, because we do know that many times, unfortunately, we see across the globe, in the settings all over the world, that people mark the chart of the client, for example, saying he's disclosed, and it is assumed that all the information is there. But as we know, and as I mentioned before, first of all, we don't know what was exactly told, and many times in the home circumstance or community circumstance, information that provided about HIV during disclosure might not reflect the current evidence of science, the current outlook on the lifespan and quality of life. It might include some information. For example, we have run into that. You all have known that a young girl who lives with HIV might be told she will never be able to marry a man without HIV diagnosis, and things like this. This is just one of the examples. And we definitely have placed a big emphasis on post-disclosure management with very concrete tips. And throughout the tool, we do address the barriers. We do provide the tips how to handle challenges.
Thank you so much.
Quickly.
Oh, sorry. Okay.
Sorry,
go ahead very quickly. Yes.
Yeah, one of the other questions was the tips. If we have tips on healthcare workers, how they can handle some difficult scenarios. And indeed, we do have tips. For instance, one of the most common one is a caregiver who totally refuses for the child to be disclosed to. And we've given a number of tips for healthcare workers on how to maneuver this and deal with this until they get to a point where the caregiver approves, and then they can go on with disclosure.
Thank you so much, Dr. Natella and Dr. Judith. We actually have quite a few questions that have come in, so I'll go ahead and give you the next 3 questions. Raphael is asking, how do we objectively assess the developmental age of the child? Mage Dragai is asking, what are the key capacity building or skills building aspects caregivers should have to effectively disclose? And then she's also asking, what is the role of religious leaders? Renato Pinto is asking, first commenting to say, great that the toolkit will be translated into Portuguese. When will it be ready? Will there be printouts or will it just be available online? Over to you.
All right. So, thank you very much. These are all great questions. So let me start backwards. I don't think I was right in the first 2 ones, but I will get back on those. So capacity of, developmental stage is the first one. I think I skipped number 2, but let me cover what I have. So the role of religious leaders can be very important. We mentioned under the community. We did not put a specific emphasis on the religious leaders, but as a part of the community support, definitely is mentioned at some point, and I do think involving community in support and disclosure is crucially important. Disclosure is not only the family matter, and when we talk about social networks, we talk even scenarios of work, place disclosure, etc. It is just for us as a part of the support community that can be involved and can have an incredibly positive effect on the disclosure. I personally think also that religious leaders frequently might know more about certain networks of people and familiar relationship that can interplay in a complex scenario of disclosure, and their capacity to confidentially master it and leverage the knowledge within community can be of crucial help. So again, no specific reference or place dedicated to, but definitely recognizing the role of religious leaders within the community. I will go back to the issue of the hub assuring the capacity of the caregiver. We do spend quite a bit of time talking about how to incapacitate caregiver in the disclosure. I think one of the major elements is to talk to them openly about the barriers, and that is spoken in the toolkit. Everything I referenced there is to speak to them about the fears, to recognize the fears. I think one of the mistakes we make with caregivers is we just present them the positive side. It's a dialogue. They need to be convinced. You need to get the buy-in into disclosure. So as mentioned by Judith, some of this will take multiple visits and multiple conversations where you finally reach that buy-in from the caregiver. Second most important element is they need to start seeing some positive in it for the person and themselves. The second element in that is evidence-based, and that is where I think a lot of issues are, because you really need to spend time educating caregiver on, according to his or her knowledge, educational level of the basics of HIV, so they can really interpret it right. And it doesn't need to be complex. It's indeed, as Kaya, as Joshua pointed out to us, need to be very simple language. But the concepts like HIV is not a killing disease if it's taken care of well, explaining how the drugs work on a very simple way, things like that. So I do think there's two major elements: getting caregiver buy-in, making them feel that it is a good thing to do after all the challenges are recognized and acknowledged. And second one is equipping them with an evidence. And the probably final one is to truly giving them the tips and maybe involving them in a case-play scenario, saying, okay, when you do it, let us practice. Let me sit with you. Let us practice. What would you say? So these are kind of a few elements. I do have recorded a question about developmental assessment. Thank you for this question. It's extremely important questions. We do provide the reference to some resources in the tool that are available on the continent that have been approved for the global use for the developmental assessment. By saying that, I do recognize that there is a lagging of this capacity on the ground, and not all caregivers are capable to really do comprehensive developmental assessment in a pediatric patient, but some general tips of like how's the school, capacity of the child to deal with the peers, whether his school performance is up to par, some elements, very, very gross elements of developmental assessment, some tips we provide, but we do also provide the resources that are available on the continent for developmental assessment. I think I retained 3 questions. I believe there was one that I must have skipped. Judith, do you want to take one, or do you have it written, or do we need to ask Nande to repeat it?
I think there was a question on recommendation for post-disclosure support.
Okay.
And I think on the tool, in the algorithm, we have a step 4, which is post-disclosure assessment, basically looking at areas around how well are they doing in school, how are they relating with others, how is their interest and level of activity, mood and behavior and adherence monitoring, so that based on the assessment, then you refer them for further support, be it a counselor or a psychologist or any other support. So that's all documented and described in the toolkit and also in the algorithm.
Nande, if we skip any question, please do kindly repeat it. I do have a paper now in front of me, and I'm able to write it down.
Okay, sure,
Natella. When Portuguese will be ready, I don't know.
Yes.
Natella, you can.
Portuguese version in just a couple of weeks, we anticipate. It's in works. It's already, to my knowledge, the bulk of translation has been completed. There is a proofreading and verification going on.
Thank you so much. Really, it's an interesting subject, lots of questions coming in. In the interest of time, I'm going to group some of them. Some of them are very specific around the thematic area and implementation of disclosure. And then there are some which are about additional information, which maybe you can group together. There's a question about data source on partial disclosure and full disclosure. There's a question of, specific to how does Kenya go about disclosure via healthcare providers, trying to make comparisons with how it's done in Lesotho. And then there's also that question you addressed on when the kit would be available in Portuguese and whether it's just online and by print. So maybe you might package those questions into one response about further information about the kit, where it will become available, where people can find out more information about data sources, and who are key contact persons in country who, if more conversations would like to be had about the subject, they can contact those people. Okay. So I'll group that as one question. And then we have another question from Dr. James asking, during pilot testing, was there any indication of which group adolescents prefer to discuss this topic with? Was it caregivers? Was it healthcare providers? Was it peers? Another question from Elizabeth Okoth, does the toolkit address how adolescents may deal with any form of violence that may come up with their partners on disclosure?
Yeah.
Okay. And then a third question, which I think I'm calling a last question. Some health workers have stigma and are finding it difficult to support caregivers to disclose. How can we help these healthcare workers to get out of stigma? Over to you.
Great, thank you so much. And these are all wonderful questions. And I just want to start by thanking, first of all who listen and all who so actively engage. So to go over the first, which I'm going to try to sum up a lot of questions about the tool. You see on the slide the website. It's an EGPAF website. The tool is available there in English and French. The Portuguese version will be also published there as well. It is absolutely free to download. It's printable. It's not a large volume of pages. It does take some color if you're doing it in a color printing, but you can also choose to omit the most color consuming pages. You can also print it by units. Let's say if it's a center that doesn't deal with adolescents, only pediatric, you can select to take only those. All information in there is evidence-based. We provide extremely large list of references. They are broken down thematically, so you can really find references to everything we're saying. We have used the references, either the global tools, which I already mentioned, you said ANECA, etc., Baylor book, to the articles and excellent reviews, WHO documents available. So again, we are very proud to say this is the first tool that is a fully evidence-based, and I don't want to take more time, but all the references can be found there according to the modalities, and you can use them. And if you ever need any support in locating them, we will be absolutely available. There are person at EGPAF that would be contacted, and we can absolutely happy to share the email address as a follow-up or webinar or attach it to webinar. It's Katie Wallner. She is the one who really helped us to put the tool together. She's at headquarters in Washington, D.C. and working together with us as a project manager. And there is also another address that is more general, and you can just use it. Since you heard us introducing it, it's a tool that is developed with New Horizons. If you just type New Horizons as one word, New Horizons as one word, at pedaids.org, pediatricaids.org, pedaids, it's EGPAF. This is where we will accumulate all the questions, all the follow-up tips, and connect you to the right people. The question came in also about implementing, and I do want to say that in the EGPAF countries, we are happy to serve as a point for this tool. So our programs in the countries where EGPAF are well aware of this tool, and just reaching to them might be a really good bridge to work with us. But if you want to know to whom and how to connect with countries, please reach to us through newhorizonspedaids.org, and we will be absolutely happy to coordinate you with the right partners and countries, including MOH contacts, if it is of interest. Second question, during pilot testing, there was a question where adolescents more interested in engaging with the caregiver, healthcare workers, peers about that. I will refer this one to Judith, and maybe if Joshua wants to comment on that.
No, I was thinking maybe, Joshua, you want to comment? Who do the adolescents prefer to disclose to? Is it the caregiver, healthcare workers, or peers? I think this was discussed in your discussion.
Thank you so much. First and foremost, adolescents do want to disclose to their peers, mostly because they have trust in their peers more than their parents. As a peer, the way we talk to one another is much more or less different from the manner in which we talk to our parents. That's why they prefer disclosing to their peers than disclosing to their parents. Thank you.
Thank you, Joshua, very much. And again, this is a wonderful discussion, and I think the amount of questions and the depth of questions to me just speak up that we need to have more communication on that subject. I will go ahead and move on the last two questions, and one was around the adolescents and the potential implication of disclosure as a violence. Absolutely, we do address this. We don't go into greater detail of it, but there are great resources about GBV provided. We discuss what is available in the literature, actually dismissing some, and it links to my question number 4, dismissing some of the fears around potential overwhelming level of violence and disclosure, but recognizing it is a potential consequence and addressing and providing the proper resources to talk about the violence and gender-based violence. And then finally, last question. And by the way, when I mention resources, it's not just papers, but we also have web addresses directly built in that can connect to the global resources. And then final question, which I think is the most challenging one, is how to overcome the stigma in healthcare workers and their reluctance or fear to do that. And my question are two-sided, is provide them with the knowledge and the simple tools, provide them with the talking points that they can use, and most importantly, provide them with benefits also and quotes. I think that's one of the reasons we included quotes. We wanted them to see how empowering this experience can be. But most importantly to me is put them through the exercise of doing that, and that demystify it, make them play it, make it a fun interactive experience. And once the person have taken on the role of 1 or 2 scenarios, which we really hope to take place on the ground, they usually will kind of overcome some of it, or at least they will bring their fears more openly, and within the group exercise they can be leveraged. So active learning. Back to you, Catherine. Nande.
Okay. Thank you so much, Dr. Natella and Dr. Judith. We are forced to ask one more question because there's been such enthusiastic participation. Emilia Iwu is asking, considering the current conversation about U equals U, how did the adolescent advisors discuss the implications of this with partner and social disclosure? And before you come in, Joshua, there were 2 other questions. One on, you indicated how Uganda is nationalizing this. What steps would we need to replicate this in Kenya? Deborah Frank asked, how can we tell if a caregiver or adolescent is ready for disclosure? How do we measure that? My thinking is it probably the algorithm would help with that. But Dr. Natella and Dr. Judith, do you think it would be fair for us to refer those questions to the toolkit and that these are directly addressed there? Over to you.
Yeah, I think so. And we would be happy very much to take on and continue the dialogue about some countries interested in a national approach. You are right to say Uganda was very interested. MOH reached to us and took the tool as well, considering to including or referencing it in the national adoption. We are extremely enthusiastic to work with partners around that. So I would say, please continue talking to us on that subject. U equals U is my favorite question. I'm absolutely delighted it's coming to them. It's like icing on the cake. We did include language about U and U in the disclosure in adolescence. In the era of today, even the disclosure to partner is becoming, is strongly evolving as U equals U is really a reality on the ground. And we address this, and we address maybe somewhat challenging issue on the continent. I go to the field, I talk to providers. I know the universal motion of instructing adolescents of always disclosing the status to the sexual partners, but this is not what we are saying to the people on the other end of the world. The young people on the other end of the world are very familiar with U equals U concept, and And we've really made sure that in a culturally sensitive manner, we did include this, and we are advocating for U equal U, guiding the support to adolescents in disclosing their status to their partners, and definitely being a very strong element of education on that subject to them.
Thank you, Dr. Natella. Allow me to give a few brief points to summarize our discussions and webinar today. We were introducing a disclosure toolkit that has undergone an extensive process in its development and validation. It's a key contribution to our programming in delivering services for children and adolescents living with HIV. So much so because disclosure is a key barrier to uptake and retention, and ultimately good outcomes for children and adolescents living with HIV. It's a very comprehensive toolkit. It has guidance and checklists for disclosure, which are relevant to healthcare workers, caregivers, horizontally infected adolescents, adolescents to social networks, communities, and partners. It also has job aids that includes algorithms, readiness assessment checklists, and role-playing scenarios. This toolkit is available on the EGPAF website. I believe we've shared the link by chat box, but this will also be available in the summary that will be circulated through the Children and AIDS. And it's going to be available in 3 languages, currently in English and French, soon in Portuguese. It's currently being disseminated by EGPAF officers, but I believe that after this disclosure, which has had such great participation, the last time I looked, we had 93 participants online, who I'm sure represent a broad range of organizations and ministries of health. And I also want to acknowledge Joshua, who for me really is a champion of disclosure. And he really signifies to us the important role that peer groups, teen groups, youth support groups play as partners in ensuring that disclosure ceases to be a barrier in us delivering quality services for children and adolescents living with HIV. He highlighted also some exciting innovations, speaking of the use of WhatsApp for real-time support for adolescents, also talking about the fact that Kaya had developed cartoons. And so would like to encourage Joshua and his group to continue to do that, and hopefully his testimony will inspire all the different peer support groups and youth groups that are doing remarkable work in the area of HIV programming. I want to close by giving thanks through the statements of 2 participants. Jacqueline Balungi said, "Thank you so much for this webinar. To me, it's been an opportunity to learn that there are disclosure materials and tools now available online, and we are going to explore and implement in our day-to-day encounter with children and adolescents at the Bela, Uganda Center of Excellence Clinic as we await final guidance from the MOH." And then we have Alice Sasa, who I think had such a wonderful way to close this webinar. And she said, "Well-managed disclosure transforms lives." So with that, I'd like to give immense thanks to Dr. Natella, to Dr. Judith, to Joseph, and to each and every one of you for participating so actively, and really hope that this is the beginning of impactful change for children and adolescents living with HIV.
Great. Nothing else to add except, of course, thank you to all. Thank you to the presenters, Dr. Rakhmanina, Dr. Nande, Putta, and Joshua, as well as all of you for joining on the call. I'd just like to say that if you have any further questions, or if there were any questions that didn't get followed up sufficiently, send them to my colleague Rike, whose email is on that last slide of the presentation, and she will make sure that we follow up those questions with EGPAF. I just would like to thank everybody. I think that it will be very useful to you in your work. I thought that just in closing, let us recall what Dr. Rakhmanina said at the beginning. You know, disclosure, when it's done right, really empowers everybody. So I think that's a good parting word, and just to say thank you to everybody. Have a great day or a great evening.
Thank you. Bye-bye.